So here we have the first the screen is visible. Okay. So yeah, so this is the first OSCE. Identify the device. What is the principle of this device? What is set technology? And what is perfusion index? So yes, it's a multi-para monitor, right? Principle, any law you know of? Very good. Beer-Lambert law. Yes. Set technology. Good. Signal extraction technique. Yes. And PI. So I can see a lot of correct answers. So, okay. Yes, so the principle is a Beer-Lambert law where the concentration of an unknown solute in a given solvent is determined by light absorption. So the reduced hemoglobin will be absorbing the red light, that is 660 nanometers, while the oxygenated hemoglobin will be absorbing the infrared light, that is 940 nanometers. And SpO2 is determined by oxyhemoglobin upon oxy plus deoxyhemoglobin. Set technology, signal extraction technology, and this is usually the principle of the Massimo pulse oximeter. And here what it will do is it will identify the venous blood signals, it will isolate it and also filter it. So thus it works very nicely in low perfusion states whenever there is a motion or a noise artifact. And rightly answered, perfusion index is the ratio of the pulsatile to the non-pulsatile blood flow. Yeah, so coming to the next OSCE. So a late preterm male neonate presented with extensive peeling of the skin over the trunk and extremities on day 22. The oral cavity was involved, nails were dystrophic, and there was negative family history. So what is the probable diagnosis? Name two differentials of this condition and the components of wound care. Yes, correct. Epidermolysis bullosa, right? Yes, I can see some differentials also. Okay. So yes, I think, yeah, some of you have got it right. Epidermolysis bullosa. It's not staphylococcal scalded skin syndrome because of these two things. The oral cavity was involved and also the nails were dystrophic. So this is more pointing towards epidermolysis bullosa. The differentials would be bullous impetigo, staphylococcal scalded skin syndrome, and pemphigoid. And here, whenever we are dressing, what is more important is there should be three layers. So one should be the contact layer, which is basically, it should be silicone-based dressings. The second layer could be a gauze piece. And the third will be the securement of the dressing with a net. So the 2022 classification, so epidermolysis bullosa. So there are four types. The simplex is when the epidermal proteins are affected. Junctional EB when the proteins at the basement membrane, around the basement membrane are affected. dystrophic when it's the dermal proteins affected, and mixed when several layers are affected. Okay, so the third OSCE. So an antenatal ultrasound at 24 weeks was suggestive of renal APD of 16 mm on the right side and 19 mm on the left side. LICA was normal. Parents have come for antenatal counseling. So what other parameters would you like to know in such a case? And what is the schedule of postnatal ultrasound in a baby? Any answers? Yes, very good. Any schedule for the postnatal ultrasound? So I'm talking about postnatal. Yes. MCU. Okay, so yeah, the other parameters as rightly answered is corticomedullary differentiation. We need to see whether the ureters are also dilated, the bladder wall thickness, and also the other soft markers which will point towards the genetic cause. Classification, so this baby has a 16 and 19 mm APD. So definitely it will come in severe antenatal hydronephrosis. So antenatally, whenever there is a unilateral hydronephrosis, antenatal ultrasound is to be done in the third trimester and postnatal at 3 to 7 days. Whenever there is a bilateral severe hydronephrosis, serial antenatal ultrasounds at 2 to 6 weeks have to be done. And in cases where there are soft markers, we need to refer to for genetic counseling. And yeah, so based on this, we can see that whenever we have an evidence of severe antenatal hydronephrosis, which can be like bilaterally severely dilated pelvises or the callaceal dilatation, or there can be bladder dilatation, or there is oligohydramnios. In that, we need to do a postnatal ultrasound in the first 24 hours. Otherwise, it can be done in the first week. Based on the first ultrasound, it can be graded as no hydronephrosis, mild and moderate to severe. So that is based on the SFU grade 0, 1 to 2, and 3 to 4, and APD less than 7, 7 to 10, and more than 10. Whenever this is a case where there is no hydronephrosis, we don't need an intervention, but we need to follow up with another scan at 4 to 6 weeks. So 2 negative scans done postnatally will clearly rule out hydronephrosis. In cases of mild hydronephrosis, serial ultrasounds done 3 to 6 monthly, while in moderate to severe, we need to do an MCU. And based on the MCU, we need to discuss further. So if there is no VUR, we can do a renography. If it is not obstructed, again, we can follow it with ultrasounds. And if it's an obstructed pattern, then the differential fraction is less than 40 or it is declining over time. So we need to go for surgery. VUR, again, these cases will need a long-term antibiotic prophylaxis. And whenever we have a lower UTO, probably a PUV, so their case, we need to have go for urgent surgery. So coming on to the next OSCE. So a G2 mother, 26 weeks gestation, O negative blood group. Husband is O heterozygous D positive. Previous pregnancy anti-D status was not known. ICT in this pregnancy is 1 in 32. So what are the various RH antigen types? And what is the next step in this scenario? Also, what is the value of MCA PSV, which is considered to be associated with fetal anemia? Okay, so the various RH antigens are D, C, and E. Mostly it is D. So this flow chart would be very helpful in discussing this case. So whenever a mother comes with for the first antenatal visit, we have to see the RH status of the mother. If she is negative, then we have to also see the RH status of the husband. So if the mother is RH negative and the husband is RH positive, we need to perform an ICT. So ICT titers negative, we will be following this ICT titers every 4 weeks. At 28 to 32 weeks, they will receive 1 dose of anti-D, 300 micrograms IM, and which will be repeated within 72 hours of birth if the baby is RH positive. Now, if the ICT titers are less than 1:16 dilution, we need to repeat titers every 2 weekly and delivery can be at normal time. Again, in these cases, you do not need an anti-D because they are already sensitized and they have antibodies. ICD titers when they are more than 1:16. Now, in these cases, we need monitoring every 2 weeks. And this is with an MCA PSV and a higher looking for the features of hydrops. So at any time when the features of hydrops are present, and if 2 repeat MCA PSVs are more than 1.5 MOM, 1 week apart. So in those cases, we have to do a chordosynthesis. And if fetal HP is less than 10, they have to go for intrauterine transfusion. So if we are giving an intrauterine transfusion, it will depress and suppress the fetal bone marrow. So these cases will require frequent intrauterine transfusions. The first one would be after 2 weeks and then every 3 weeks. And delivery should be at around 35 weeks or later. So the next OSCE, so we have an X-ray over here. So baby is born at term gestation, weighing 3.2 kg, was referred from a peripheral hospital in view of persisting respiratory distress at 10 hours of life. So yes, I can already see all the answers. So the condition, yes, it is CDH. So important antenatal prognostic factors. And with respect to the delivery room management in such a case, what should be avoided and what should be done immediately. Yeah, so almost everyone has got it right. So yes, this is a left-sided congenital diaphragmatic hernia. The prognostic factors are extent of lung hypoplasia, which is usually seen with by the observed to expected lung head ratio, and more than 50%, it's a good sign. Position of the liver is also important because if the liver is down, it is again a good prognostic factor. And also we need to see associated anomalies where other GI anomalies can be associated, congenital heart diseases can be associated. Yes, so we have to avoid bag and mask and immediately put an orogastric tube for bowel compression. So here we see an amplitude integrated EEG. So identify the pattern. What are the other types of background patterns you know of? And what would be the upper and the lower margins in a normal continuous pattern? So quickly moving on. So this is a continuous, normal continuous background activity. Here we see I'm these areas of discontinuous or narrow bandwidth and areas of wide bandwidth which are continuous. So this is a normal sleep-wake pattern and this is a continuous pattern. So seeing the upper and the lower margins. So for a continuous normal voltage, the upper margin would be more than 10 and the lower margin would be more than 5. For a discontinuous, the lower margin would be suppressed and it will be less than 5. In burst suppression, the lower margin would be less than 5 and the upper margin is more than 10 and at times it can be even as high as 25. And during the suppressed states, the lower and the upper margin would be reduced. In the continuous low voltage, the upper margin is less than 10 and the lower margin is less than 5. While in the isoelectric, both the upper and the lower margins would be less than 5. So this can always be in one of the spotters. Okay, so the next OSCE. So what is this view and what does it show? So this is a 2D echocardiography, and what does it show? What, yes, so most of you have answered it right. So what are the echocardiographic criteria for HSPDA? And name some trials on pharmacological versus conservative management of PDA. Great. So yeah, so this is a short axis view, or we can also say a ductal view in 2D echocardiography, and it's showing a PDA with left to right flow. And what are the various criterias? So yes, the most important criteria is the size of the PDA, where more than 1.5 is a moderate to large PDA, and the second important is the LA ratio. And the trials are the PDA Tolerate trial, Benny Douglas, and Baby Oscar trial. The LA by AO is not more than 1.5. It would be, yeah, one would be more than 1.4. So identify this chart. So any answers for this? Yeah, which growth chart it is? Any idea? So what type of growth chart it is? So here we have the answer, yes. Intergrowth 21, somebody correctly answered it. So what does intergrowth 21 stands for? And give two examples, each of a reference and a standard chart. Yeah, so this is an intergrowth 21 chart. It's a growth standard. And intergrowth 21 is the International Fetal and Newborn Growth Consortium for the 21st century. So what are the reference chart? So these chart describe with the growth of a population. So without taking into consideration the ideal conditions. While in the standard, it is how a neonate would be growing in ideal condition. So the reference chart will show you how babies are growing, and standard shows us how babies should grow. So answering the next part, so the reference growth charts are as they can be intrauterine, postnatal, and fetal infant growth charts. So intrauterine, some names you should be knowing, Lubchenco and the Brenners. Postnatal is the Ehrenkrantz, and fetal infant growth chart are Babson and Benda. And the Fenton's has been formed from the Babson and Benda study. And the growth standards are the WHO charts and the Intergrowth 21. Okay, so identify this chart. Name some recognized hyperbilirubinemia neurotoxicity risk factors. Yes, everyone is correctly answering it. And I would like you to answer the third part, some other charts which can be used. Yeah, so this is American Academy of Pediatricians, and you have to mention 2022 clinical practice guidelines for newborn infants more than 35 weeks. Yes, I can see the other charts also. Yeah, so the neurotoxicity risk factors as described in these guidelines is an albumin less than 3 gram per deciliter, isoimmune hemolytic disease, G6PD or other hemolytic disorders, sepsis, and significant clinical instability in 24 hours preceding the event. And the other charts are the NICE clinical guidelines and the measles chart. And here we come to the last OSCE. So identify this. So prenatal and postnatal, the risk factors for this condition. And the various preventive and the treatment measures. So yes, some of you are writing cephalohematoma. Yeah, looking like this, yes, it can be a cephalohematoma. But I wanted to ask about the head shape. So the question is about the head shape. Yeah, cephalohematoma would not be a wrong answer in this case. But about the head shape, it would be a plagiocephaly. And the prenatal risk factors would be an abnormal uterine shape, overcrowding, oligohydramnios, and the postnatal would be sleep positions and craniosynostosis. Prevention is having frequent changes in the sleep positions and not to have a preference. And the initial treatments could be just alteration of the positions, tummy time, physiotherapy. Helmet therapy can be tried around 6 months, and later cases and those associated with craniosynostosis will go for corrective surgeries. Yes, so that's it. Sir. Okay, so I think we can end the session.
Thank you, Doctor. That was a nice session. Thank you, Dr. Vivek. Thank you, Dr. Munmun. I think we had two detailed case discussions today and followed by detailed OSCEs. Thank you, everyone, for joining.
Thank you, sir. Thank you, ma'am.
Thank you. We can wind up the sessions today. Thank you.